Our first speaker, Harriet, Dr. Harriet Hopf, is a professor and director of the Translational Research and Department of Anesthesia and an adjunct professor of bioengineering at the University of Utah. She moved from California to Utah 3 years ago, where she was a professor of anesthesia and surgery and director of wound healing of a wound healing laboratory. She received her BA from Yale, her MD from Dartmouth. She completed a surgical internship at the University of Minnesota, an anesthesia residency at the University of California, San Francisco. She spent 2 years as a research fellow at the UCSF. Dr. Hopf is board certified in both anesthesia and undersea and hyperbaric medicine. Her research focuses on measuring tissue oxygenation and improving wound healing outcomes by increasing oxygen delivery to the wound. Dr. Hopf.
Thank you very much. It's a pleasure to be here this afternoon. When I was in the parking lot on the way over here, I ran into a colleague, and she said, what are you all dressed up for? I said, speaking at the Ogden Surgical Medical Society meeting, and she said, oh, you've really arrived. So I realized what a great honor it is to be here. I'm going to be talking today about wound care, largely about basic wound care, but I was asked by the organizers to include a section on transcutaneous oximetry and when to use it, and a section on hyperbaric medicine, so I'm going to do a little diversion to those topics towards the end. So my goals today are to explain to you well the basic requirements of and impediments to wound healing, and then to understand ways that you can address these requirements and impediments in your patients. And finally, we're going to look at some various wounds, and I'll ask you to use what you learned in this lecture and tell me how you would manage them. So this is just, thankfully we're not eating lunch anymore, a picture of a typical wound. I'd like you to keep that picture in mind. I'm going to ask you about it a little bit later in my talk. This patient was about 90 years old, spoke only Italian, oxygen-dependent congestive heart failure, venous insufficiency, and bumped into her coffee table at home, and had been admitted about a month earlier to a skilled nursing facility and had been there and was sent to my clinic with the hope that I could help figure out how to heal this wound. She actually expressed when she came to my clinic the hope that she could get out of the skilled nursing facility and go live by herself again. And I wasn't sure we would get there, but I was hoping we could heal her wound. So what is required for good wound healing? I think of it as requiring 4 things. First, you need a signal, and that's inflammation. The body needs to know there's a wound and needs to know what to do about it. And that signal generally is macrophages, which guide the healing process by making various growth factors and cytokines. Then you need building blocks, which is largely protein. If you're going to make a scar, you're going to need to make collagen. Collagen is a protein, so you need to have protein. You need energy, and by and large the energy for wound healing comes from oxygen. Some of that is from oxidative metabolism, that you need mitochondria and working there. But as I'll talk later, some of the energy you need from oxygen is molecular oxygen for enzymes that require oxygen to perform their processes. And oxygen really is all about perfusion. And then you need a proper environment. You can't have a wound that's too dry or too wet. If it's getting damaged all the time, if it's full of dead tissue, it won't heal well. So you have to figure out some way to make a good environment for healing. So why do we get impaired wound healing? Well, chronic wounds often start as a minor injury. As this woman ran into her coffee table, and now she's got a giant gaping wound on her leg, but it doesn't seem like running into your coffee table should, end up as an amputation someday. But in general, what happens is you have a minor injury that fails to heal because one or more of the previously discussed requirements aren't met. And in fact, often not only do these wounds fail to heal, but they get bigger and bigger and bigger. So to make it into a healing wound, you need to identify what is the impediment to healing, and then you need to correct that impediment, and then it'll go on to heal, which sounds lovely. although in experience it's not always easy to correct some of the impediments that you run into. When I think about impaired wound healing, I'm going to break it down into these 4 component parts. So we have inflammation. And the fascinating thing about wound healing is that if you have either too much or too little inflammation, you don't heal well. So you need to have exactly the perfect amount of inflammation. In fact, we don't now know what is the perfect amount of inflammation, and there's a lot of people in the wound healing world who are trying to figure out what is it that you need for inflammation and how do you optimize wound healing. Not just how do you make people heal normally, but how could you make them heal better than normal by controlling what growth factors and cytokines and cells are there at what times. But inadequate inflammation would often be caused by steroids, decreased platelets or decreased white cells, any kind of severe injury or illness. You can get an impaired inflammatory state where you don't get good healing. Excess inflammation is also quite common. If there's a chronic infection, the neutrophils produce all kinds of proteases that cause impairment of wound healing. Excess inflammation in that way is bad. Ischemia, reperfusion injury, and 2 classic examples of that are pressure ulcers, where you get pressure over a bony prominence that's released periodically, and you get an inflammatory response to that, and venous insufficiency, where during the day the legs swell up and then the swelling goes away when they sleep at night, and so they get impaired oxygenation followed by adequate oxygenation. Those both cause a huge inflammatory process, and both pressure ulcers and venous ulcers tend to be very highly inflammatory. And some of them actually, of the venous ulcers, respond to steroids. Foreign bodies cause inflammation, and then there's pathologic inflammation, for example, pyoderma gangrenosum or a vasculitis. One note about steroids. So we all know steroids lead to bad healing, but they're often given to lead to survival from bad diseases. The reason steroids impair healing is that they actually prevent macrophages from coming into the wound. And so what you have in steroid-impaired healing is usually a wound that's just white. It's fatty and white, and there's nothing going on in it. And that's because there's no inflammatory cells in it driving the wound healing process. The good news about this is that vitamin A actually can reverse this. Vitamin A actually is a pro-inflammatory vitamin that draws macrophages into the wound. You can give patients 25,000 international, that's a big dose by the way, 25,000 international units daily for 10 days. It's a fat-soluble vitamin. You don't want to give it longer than 10 days because it can build up in the liver. And those of you who are polar explorers know that if you ever are stuck in the Arctic and you kill a polar bear, you don't want to eat its liver because that'll kill you because of all the vitamin A. So don't kill people with the vitamin A, but go ahead and give them some for 10 days. The other nice thing is you can use it topically. Topical Amd Ointment, you can get it at the grocery store, you know, the diaper rash Amd Ointment. It has vitamin A in it, and it works very nicely actually to reverse the problems of steroids. The one thing to be aware of is oftentimes those steroid-treated wounds are infected, but you can't tell they're infected because the thing that makes you know that something is infected is the inflammatory response. And what we frequently see is that a week or 2 after we start the vitamin A, the wound suddenly turns bright red, and we treat them with antibiotics. I don't believe that it's because the vitamin A is causing an infection. I believe it's because the infection was there, and now the body is demonstrating that it's there. Okay, so building blocks, protein. Malnutrition impairs wound healing. That's very clear. The key ingredient there is protein. Protein is required for collagen synthesis, and as a double whammy, not only do you need a lot of protein to heal a wound, but if you've got an exudative wound that's weeping, it's weeping protein. So those patients actually kind of need double protein. The good news here is the recent intake is most important. So if you've got a cachectic patient, a thin patient, and you can replete them for a week, they actually get their healing back to close to normal long before any of their other measures go back to normal. Arginine is a special amino acid. Let's step back from that. There's no special protein to eat for healing better in terms of just being protein. Arginine is special as an amino acid because it seems to have pharmacologic effects. So if you give big doses of arginine, about 400 grams a day, you can actually make volunteers heal better in test wounds. 400 grams a day, unfortunately, isn't well tolerated by most patients. It's fairly osmotically active in your intestines. But there are some protein supplements that have a higher amount of arginine in them. And it's working pharmacologically probably through nitric oxide. No one's exactly sure what it does, but it does certainly help. And then the other thing that's not a protein that's important in nutrition are vitamins C, A, and zinc. Vitamin C is very clearly important for wound healing. We all know that the first randomized controlled trial in medicine was done in 1747 by a British naval surgeon named Lind, who demonstrated that if you gave what he didn't know was vitamin C, but vitamin C containing vegetables to sailors, you could prevent scurvy. And scurvy is the lack of vitamin C causing the triple helix of collagen not to be able to form, and vitamin C is a cofactor. So you get the procollagen, and you need to hydroxylate the proline and lysine residues in order for it to be able to make the triple helix that makes it strong. Vitamin C is a cofactor for that, and when you're missing vitamin C, you don't make that. So Lynn didn't know that, but he did do the first randomized controlled trial. I would note he had 8 patients in the trial, changed the course of history, but could not have published in the New England Journal of Medicine. So that's a fascinating little fact. So vitamin C is clearly important, and I think every patient with a wound should be on vitamin C, 500 milligrams once or twice a day, not a massive dose, but just enough. Vitamin A and zinc in deficient states impair healing, but if you get to more than normal, it doesn't improve healing. So I generally give all my patients with chronic wounds a 10-day course of vitamin A and zinc just to make sure that they aren't deficient, but I don't go beyond that. The environment is very important for a wound. If there's dead tissues or foreign bodies, they clearly get in the way. They cause excess inflammation, so they need to be removed. That's debridement. Dry cells die and don't heal well. Winter showed in 1962 that a covered wound, a moist wound, healed 40% faster than a dry wound because the epithelial cells at the edge in a dry wound are not able to migrate because they're dead, whereas if they're kept moist, they can migrate across. So you don't want to be too dry. On the other hand, maceration is just as bad. Your skin likes to be dry. Granulation tissue likes to be moist. And our big challenge in epithelialization is, how do I keep the new skin dry but the edge is moist? We don't actually have a good answer for that yet. Cytotoxic agents make the environment poor. So hydrogen peroxide, betadine, mercurochrome, alcohol, bleach are all things that impair wound healing. They do kill bacteria extremely effectively, but they also kill your fibroblasts and white cells so that nothing happens in the wound. So if you have a patient who's using hydrogen peroxide, I actually love it when a patient comes to me who's got a non-healing wound who's been using hydrogen peroxide because I know all I have to do is make them stop and everything will get better. But the wound comes in and it's white and it's clean and it's fabulous, but it's not doing anything because there's no healing components in it. Tap water, my favorite thing. Works great, cleans the wound. Don't use anything cytotoxic. Trauma, so this is the classic diabetic foot ulcer. They're neuropathic, they're walking a hole in their foot. I had a patient who was wheelchair bound, didn't like to be slowed down, and she went around and just kind of threw her feet around and would drag herself around places and always had wounds and was coming in to see us. And she said, I've got this problem, I don't heal well. And I said, no, you actually heal fine. It's just that every day, every night you sleep and heal up what you injured during the day and you just can't keep up. So trauma is a huge problem, and pressure and trauma really go along together. Trauma can be sudden and blunt. Pressure is over time. And then we get to oxygen delivery. I'm going to spend a little time on this because, as you found out in the introduction, this is the thing I care most about. It's also extremely important for healing wounds. So how does oxygen get to wounds? It gets there through perfusion. Things that can get in the way of perfusion include vasoconstriction. I'll talk a little bit more about that later. Vasopressor agents. Smoking is clearly bad. Smoking 2 cigarettes reduces your wound oxygen level by about 40% for about an hour. Starts about 10 minutes after you smoke, stays for an hour. So if you have a 1 pack a day smoker, 20 cigarettes, it's only while they're sleeping that they may have any semblance of normal wound oxygen levels. And we know they don't heal well. Edema reduces blood flow, and then arterial insufficiency is a huge problem, and it'd be nice if we could fix that. Why is it that oxygen is so important? Well, oxygen is actually required for all the components of wound healing. The first step when you have a wound is prevention of infection, and the first cell in the wound is the neutrophil. It's the primary cell in the wound within an hour or two, and it leaves by about 24 hours as long as there's no infection. And neutrophils have a couple of ways to kill bacteria, but the one that's most important for the pathogens that cause wound infection is oxidative bacterial killing, where it converts oxygen to superoxide. Superoxide is bactericidal, but superoxide is also what turns into hydrogen peroxide and hypochlorite or bleach and peroxynitrate and all the other bactericidal radicals inside the neutrophil that kill the bacteria. Superoxide production is dependent on oxygen because it starts with molecular oxygen, and you only make about half the maximum amount of superoxide you can produce when the wound PO2 is in the range of 40 to 80 millimeters of mercury. So let's say we weren't in Utah, but we were at sea level, and your arterial PO2 was 100, then you'd expect your wound PO2 to be about 50 to 70 millimeters of mercury. Here, our arterial PO2 is around 75, so maybe our wound PO2 is more in the 40 to 60 range. What that tells you is the lower your oxygen, that even normally your neutrophils are only making half as much superoxide as they can, and you're in a very vulnerable place where if your oxygen level in your wound drops at all, you really have no ability to resist infection. Collagen deposition, I talked about scurvy and LIND and collagen. Hydroxylation of the proline and lysine residues in the procollagen to make the triple helix actually requires oxygen. So it's actually, if you have a hypoxic wound, it looks a lot like a wound in a person with scurvy because the same reaction isn't going forward. And that requires a little less oxygen. You make about half as much as you can make when the oxygen level is 20 to 25, but it also shows you that if you go up a little bit, you're going to do better, and go down and you get in trouble. Angiogenesis requires oxygen. The more oxygen you have in a wound, the more new blood vessels it makes, and you need new blood vessels to bring back continuity in the wound. A lot of that appears to be because the blood vessels need collagen to be in, to grow into. And if it's hypoxic, they don't grow into it. But there also is some evidence that some of the receptors for the vascular endothelial growth factor are oxygen dependent. And then epithelialization, skin cells migrate across the wound faster when there's more oxygen, up to even 1,000 millimeters of mercury. The mechanism isn't at all well understood, but it's been demonstrated to be true. As a result of all this, we're going to define wound hypoxia as being an oxygen level in the wound of less than 40 millimeters of mercury. I used to give a whole talk on why it's less than 40 millimeters of mercury. Now I can just say it's less than 40 millimeters of mercury because we got a lot more data after that to talk about. But if you have a hypoxic wound, it has poor resistance to infection. You don't get good fibroplasia and collagen deposition. You don't get good new blood vessel growth, and the skin doesn't cover it. This slide, just a little bit of why I define hypoxia as less than 40, is a number of studies that were done using transcutaneous oximetry, which I'll talk about later, and looking at whether patients with lower extremity ulcers healed. And this is the number you want to see, that the successful healing was generally found when the PO2 in the wound was somewhere between greater than 20 and greater than 40 millimeters of mercury. And in all of them, the higher you are above 40, the better off you are. So it's sort of a general understanding of wounds. If the wound oxygen level is greater than 40 millimeters of mercury and it's not healing, it's probably not a lack of oxygen, it's some other problem like, say, steroids. But if you're in that 0 to 40 range, wound oxygen level is probably a limiting factor in getting healing. And it's a relationship where if you look on the y-axis, that's the oxygen level in the wound, and the x-axis is, and this axis is the amount of healing. And what you see is that the lower your oxygen level in your wound goes, the more impaired the healing is, until when you get to 0 millimeters of mercury, you're really at about a 0 chance of healing. So what are some of the reasons that wounds might be hypoxic? Well, hypoxemia is one of them. You can have lung disease. Altitude, which I used to always have altitude on my slide, and then 3 years ago I moved here and realized that now it's a real reality of my life, that this may be impairing my patient's healing. One of the things I found fascinating when I moved here, though, as an anesthesiologist, my first week in the operating room, of the first 7 patients I cared for, 4 were on home oxygen. And I can tell you that in San Francisco, the Pope had to bless them to get home oxygen for people. But here, everyone's on home oxygen because even with not too bad lung disease, you're going to qualify for home oxygen. So while altitude is clearly a problem for healing, and people who climb Mount Everest and cut themselves know they're not going to heal till they get back down to about 12,000 feet, I think here it actually helps us a little bit in that people with lung disease are more likely to be on oxygen, and just a little bit of oxygen brings them above normal. So I think there's a lot of work to be done there. That's going to be my next job. Drugs can induce hypoxemia, narcotics. I want to point out that pain also induces hypoxemia. People don't take deep breaths. So you need to, in your surgical patients, figure out some way to balance that. And then hypoxemia being one problem, the other is decreased perfusion. How does oxygen get to the wound? Well, there's got to be oxygen in the bloodstream, and then the bloodstream has to get to the wound. And I talked about the sympathetic nervous system. I will a little more, and I talked about these issues a little. Radiated tissue gets an obliterative arteritis and basically loses its blood vessels, and that's why it's hypoxic. But if you look at decreased perfusion in the sympathetic nervous system, so skin, your peripheral compartment, has two roles in life. One is it's a reservoir, so if you're bleeding or dehydrated, you can lose 20% of your blood volume before your core organs are affected. And the other is it's a way of getting rid of heat, or when you go out on a cold day, you vasoconstrict and protect your heat. So the sympathetic nervous system is basically what controls skin blood flow, and skin blood flow is what controls the wound oxygen level. Things that activate the sympathetic nervous system and cause peripheral vasoconstriction and therefore cause wound hypoxia include pain, cold, hypovolemia or dehydration, and fear. And originally we did this work in acute wounds and then realized it was appropriate to chronic wounds. And clearly, if you look at the surgical environment, it's all about pain, cold, hypovolemia, dehydration, and fear. And in fact, if you keep patients warm during surgery, anesthesia naturally makes people cold. You significantly reduce the risk of surgical site infection. If you give them adequate volume, you reduce the risk of surgical site infection. There's some nice data in stress showing that stress impairs wound healing, and it does it in part through an oxygen-mediated mechanism. And we don't have any outcome studies with pain because no one's willing to give patients pain so much anymore, but there's some very nice data that relieving pain increases your wound oxygen level. When I think about chronic wounds, I think this pertains just as well. So I love surgical site infections, but if you look at a chronic wound, they're very often painful, and frequently the pain isn't well treated. We're not quite sure how to treat it. It's hard to treat, and oftentimes patients are given narcotics to treat their pain, but they won't take them. I spend a lot of time explaining to them that pain is actually impeding their ability to heal, so it's important to treat their pain. Frequently, these limbs are cold. They don't like to put their shoes on, or they don't like to cover them, so the limb is out. And one of my nurse colleagues in San Francisco, Judy West, was very interested in temperature, and she used to do our transcutaneous oxygen studies for us in the lab. And she would measure skin temperature, and she demonstrated that if you take a limb that you're measuring transcutaneous oxygen on and just cover it with a chucks, just a single towel or a thin plastic sheet, you actually raise the skin temperature by 1.5 to 2 degrees centigrade. So there's a lot of vasoconstriction going on out there to prevent heat loss to the environment, and if you can just get people to cover up their foot, that may make a big difference. I find a lot of patients with chronic wounds, they don't like to go to the bathroom because their foot hurts, they don't like to walk, so they actually limit their fluid intake. I've had a couple old ladies with black toes who, if I could talk them into drinking a few more glasses of water a day, could save their little black toes. So it's a big problem. And then anxiety and stress. There's probably not many more things more stressful in the world than having a chronic wound. So if you have a patient with a chronic wound, what is it that you need to do? Well, the first thing is really to identify what's wrong with them. What is their wound? Chronic wound is not a diagnosis. Sort of this broad category, and people like to call it something like a diagnosis, so they have a chronic wound, but all wounds are caused by something, so you need to identify what causes it. We think about 4 basic categories that cause over 90% of wounds: venous insufficiency, diabetic neuropathic ulcers, pressure, and arterial insufficiency. I'm going to talk about what the basics are in a minute, but if there's a venous insufficiency ulcer, you treat it with the basics. And compression. So you got to get rid of the edema. Well, how do you get rid of edema? You use compression. We'll talk about compression in a minute. And then also ablation. So in the last few years, the ability to ablate incompetent veins has really advanced, and it turns out it improves outcomes for venous ulcers, particularly the ones that are refractory. So that's something that people need to think about. For diabetic neuropathic ulcers, again, you need good wound care. They need debridement. They tend to make a lot of callus. You need to get rid of all the dead tissue, and you need to make them stop injuring themselves, so you need to offload them. I say that like, oh, that's a basic thing, that's so easy to do, but I can tell you if you have a 300-pound diabetic truck driver, you will never offload their foot and you will never heal their wound, which is why people find it such a frustrating area to work in. Pressure ulcers are very much, diabetic neuropathic ulcers are essentially pressure ulcers, but they're on the feet, plantar foot, instead of the sacrum, the ischium. And pressure ulcers are the same, basic wound care, debridement, and pressure relief. And then arterial insufficiency ulcer, basic good wound care, they need to be revascularized if possible, or they won't heal. There probably is a role for hyperbaric oxygen. Hyperbaric oxygen actually reduces ischemia reperfusion injury. There's no evidence to support this quite yet. There's a lot of suggestive things, but if you do a revascularization, there's some data that if you treat people with hyperbaric oxygen, it makes more rapid that recovery phase and makes more successful the revascularization. Hyperbaric oxygen would seldom be effective without revascularization in a foot that had critical limb ischemia, but in some less problematic, less impaired feet where they can't be revascularized but they have some blood flow, it can be helpful. So let's talk a little bit about compression. The idea behind compression is to get rid of the edema in the leg that's causing ischemia reperfusion injury and fibrosis and lack of healing and hypoxia. Compression should be graduated from the ankle to the knee. Ideally, you should achieve a pressure of 30 to 40 millimeters of mercury. If someone has an arterial component, frequently arterial and venous ulcers come together. Not infrequently, diabetic patients have arterial venous ulcers, and those are very challenging. But if somebody has a poor arterial inflow, you want to go to a lower pressure. I often start with those edematous legs with just an ACE bandage or something like that, I'm forgetting the name because I always try to get people not to use it. There's a stockinette, kind of a wrap that you can put on. Start with something that will start to get some of the edema gone. Start with elevation, and then eventually you want Job's stockings or one of the other personal compression stockings to keep that edema controlled. If you get them a personal compression stocking before the edema is controlled, then it's going to be too big. There are some very nice 2-layer wraps and 3-layer wraps and 4-layer wraps that do a great job of getting rid of the edema. I often start with something like an ACE wrap because if you've got a big swollen leg and you go directly to a tight wrap, patients often won't tolerate it. You need to kind of gradually get the fluid out and then go to good care. An important thing is patients should be putting these on before they get out of bed, or they need to lie down 20 or 30 minutes. If you wait till your leg is swollen and then apply a compression stocking, it's going to hurt, and you're not going to be able to squeeze that extravasated fluid back in. But if you lie down, it'll reabsorb, and then the stocking will work well. If you're a cashier and you stand up 14 hours a day and you wear compression stockings, they are going to be overwhelmed. So they really do need to elevate their legs as well. So let us go back to my lovely patient. I'm going to describe this wound a little bit. It's big. It's got a lot of slough on it. There's not a lot of granulation tissue. There's a lot of necrotic tissue here. I don't know if it's old hematoma or is it some progressive necrotic disorder. And it's pretty red around it. So how many people here think it's infected and you'd like to treat her with antibiotics? So this is a raise your hand vote. You can raise your hand, yes, I want antibiotics, or no, I don't. If you don't raise your hand for antibiotics, that means you aren't going to give them. So how many people are going to give her antibiotics? So we got maybe a third. How many people are not going to give her antibiotics? Most people. So I like to hear that. I'm delighted to hear that, in fact, because I don't think it's infected. I think it's largely inflamed. So what I did for her was I used calcium alginate, which is a dressing I'll talk about in a minute, and I gave her a 2-layer compression wrap. And here she comes back 2 weeks later, and you can see that her legs are a lot skinnier than they were, and I did the other leg as well because it was equally fat. And I like all this wrinkling. Sometimes we get upset because their legs get kind of wrinkled with the compression. That's good news to me because that means that the fluid is getting out of there, and they will become normal-looking legs when they kind of settle down. You can see her leg looks a lot better. This stuff down here is actually the dressing. I thought she was very weepy, but she wasn't. So this is just dried-on dressing, but most of the necrotic tissue has come off. I did not actually debride the wound with a knife. I debrided it with a dressing because I thought once we got good compression, all that necrotic tissue would just slough off. So here she now is 2 weeks later. And I'm not very smart sometimes, so her legs are looking nice and thin and things are going well. This is all actually the dressing still, because I didn't believe my eyes that she wasn't weeping, and I put on an absorbent dressing and it's still stuck on there. But you can see she's healing really nicely. And here she is a couple weeks later, and you can see we've finally gone to a foam, and I think that looks kind of like Italy there. And she's healing up nicely. I don't have a picture of her fully healed because her sniff at this point said, oh, I think we can handle it from here. But that is an example of a wound that looks horrifying. Very simple care makes it better quickly, especially in a 90-year-old woman who's on a home oxygen and has CHF. You wouldn't think she'd be the best healer in the world. Just some more examples of compression and why it's so important. Here's a patient who I saw. She'd been admitted over a month 3 times to the hospital for intravenous antibiotics for cellulitis. While she was in the hospital, she'd get better. She'd go home. She'd come back 3 days later with new cellulitis. By this time, she's on vancomycin because they think it's MRSA, and they've actually tried to lance some kind of an abscess. And I looked at her legs and I said, what she has is venous insufficiency, and the reason they're red is not in any way cellulitis. It's just the inflammation of venous insufficiency. We put her in ACE wraps. She came back a week later, and you can see her stab wound is basically healed up. Her whole leg looks a lot skinnier. All the erythema is gone. All my patients are problematic patients, but a lot of these are actually tape burns from where she pulls her skin off with tape, which we kept trying to avoid but couldn't do it. And here's her other leg. I'm sorry, I was wrong. This is her legs when they're not looking good. This is her right leg and her left leg. And here she is a week later. This is healing up. Her leg's a totally different looking leg. There's some issues with burns, but and then here's her other leg, which is basically fully healed. So if we can keep her in compression stockings, she can stay healed for the rest of her life. I can tell you the answer is she will not stay in her compression stockings, and so we did not manage to keep her healed for the rest of her life, but that's how my life is. I know how I could heal wounds if people could follow instructions. So what are my views on the basics of what do you need to do to a wound to basically make it heal? Well, the first thing is you need to establish what caused the wound. Is it venous, diabetic, neuropathic, pressure, or arterial, or is it some other weird thing, which is pretty unlikely? Then the wound should be washed. I say daily. It depends a little. If you put those 2-layer wraps on, they can stay on for a week. Then obviously you're not going to wash the wound daily. If I have a really compliant, useful, helpful patient, I will have them do their own dressings and wash their leg every day. If I have someone who has more trouble with that, I'll just have them come in once a week and put on a wrap that stays on once a week. But when I wash the wound, I like to do it with mild soap like Dove and lots of warm water. That's by far the best way to wash it. A lot of people are using normal saline. Normal saline is expensive. The thing I don't like about it most is it's cold, so I think it causes a lot of vasoconstriction in the wound, and you can measure wound temperature going down. But also, you don't use very much of it, 10 or 15 cc's, whereas when you get in the shower, there's a lot of water. And I was taught in surgical residency that the solution to pollution is dilution. And one of the few things that stuck in my mind as being a really important thing I learned, let's get a lot of water on there. The other thing I would say is I see patients who haven't taken a shower in a year. And I send them home and say, go ahead, take a shower, get your wound wet. And they come back and they are completely different people because taking a shower makes you feel good. And the wound really works well. I had a patient who had had a C-section and was obese, and the C-section wound had come open. And I had been trying to convince my obstetrics colleagues that they should wash the wounds with warm water. And they thought I was a little bit of a crazy person. And so we had this patient come in, and I happened to have the obstetrician with me, and I brought her in, and we got a couple buckets of warm water and just irrigated the wound with this warm water, and the wound was just sloughy and smelly and yellow and disgusting and horrible. And they thought, oh my God, this is going to be a bad thing. Spent about 10 minutes, about 3 gallons of water, and it was beefy red, healthy, beautiful, and she is now one of the big proponents of let's use a shower. So I'm a big fan of showers. Debridement, very important, get rid of dead stuff. One of the things I see a lot in surgical wounds that haven't healed well or have gotten infected is there's sutures in them, and people don't like to take out those sutures. And I agree that if it's holding something together, you shouldn't take it out, but oftentimes they're loose, and by this time it's 3 weeks out from surgery. All they're doing is preventing healing, and frequently those wounds will heal up, and then you got like a little hole, and that's going down to one of those sutures. and then you got to get a crochet hook and try and get it out, and it's hard, or you have to reopen the wound. So sutures are foreign bodies, get rid of them. Moist wound care, I'm going to talk about it in a moment, but I said before, moist wounds heal 40% faster than dry wounds. Oxygen, I talked about oxygen. You don't get oxygen from the air, so airing your wound out twice a day is not going to help it heal. Keeping it covered is, so that it's warm, well perfused, and moist. And then you want to optimize perfusion. Your patients should drink plenty of fluids. Let's say they're a kidney failure patient or a congestive heart failure patients. When I talk to these patients, they're told a limit of how much fluid you can drink in a day. I've never seen anyone who's drinking anywhere near close to that, except for those people who are always in the hospital with heart failure. I mean, there are some people who weigh over, but most people seem to weigh under hydrate. Keep the extremity warm. There's some nice fleece boots, the Rook boot that you can buy. Get control of edema with elevation and compression, and then pressure and trauma relief, which are probably the hardest things to achieve. Going to have a little sermon now on wet to dry or wet to damp dressings. How many people here use wet to damp dressings in wounds? Okay, so they remain the most commonly used dressing in the world, which I think is really too bad because of all these reasons. The first thing is they're painful. They hurt when you pull them out because they're ripping out tissue. They're very labor intensive. You got to do them 3 times a day for them really to be effective. They cause trauma. You're debriding off the debris, and that's great. They're good debriders. But right under that debris is granulation tissue, and when you pull out the debriding goop, you're also pulling out new layers of healing, so you're slowing down the healing process. They cause a lot of bleeding. They cause a lot of skin maceration. They sit there and they don't do a good job of they do an okay job of keeping the wound moist, although they tend to dry out because we don't change them often enough, and that's why they cause trauma. But they kind of slop over onto the skin, and they're wet, and they cause all this maceration of the skin. And then the last thing that people kind of go, really? They're supposed to be the cheap thing. They're expensive. If you look at the cost effectiveness of them, they cost a lot of money because there's labor involved, and okay, a piece of gauze is cheap, but you're using a lot of pieces of gauze, and wounds heal slower. So my advice would be there's very few situations in which you would consider a wet to damp dressing. So if I'm going to say I don't want you to use saline gauze dressings, what would I like you to use? And that's a challenging thing in a lot of ways because there's more than 1,000, and I think now it's up to like 5,000 dressing products that are available for wound treatment. And all of them got to market because they're better than wet to damp saline gauze dressings. So part of me says, I don't care what you pick as long as it's not saline gauze. But there's some differences. Some are expensive and some are cheap. There's almost no studies that tell you which of those 1,000 products to use because no one has compared them to each other. They've mostly compared them to saline gauze because everybody knows saline gauze isn't very good, so it's easy to prove you're better. The FDA now is not accepting saline gauze as a control group any longer, so I think that will get better. And then the last thing is there's no one product that's best for all wounds, and in fact, if you look at one wound and you use one product at the beginning, you'll probably need to change because what you're trying to achieve in the wound changes over time. So I created this table a few years ago. This is a simple, here's a few inexpensive products that are modern dressings invented after the 80s that can help you heal wounds well. And I look at them as we've got exudating wounds and dry wounds. We got a hole to fill, we've got skin to protect, and we've got to put something on it to cover it. So if it's an exudating wound, calcium alginate is actually basically dried seaweed, and it's a fluffy cotton-looking thing, but it absorbs a lot of fluid. So fluff that calcium alginate and put it in the open area. It's a fabulous dressing. It actually has probably some growth factors in it that help to stimulate granulation tissue. It wicks the wound fluid away so the wound fluid isn't on the skin and isn't on the wound itself because wound fluid turns out not to be very helpful. You can also use hydroxymethylcellulose, which also absorbs fluid. Like I say, there's other things, but calcium alginate is my favorite product. So it absorbs the exudates, maintains a moist wound environment, and protects the skin from maceration. If you have a dry wound, if it's a small dry wound, you can use a hydrogel, which is basically water in a gel form that sits in the wound and adds some water to the wound, but it isn't like pouring saline on it and macerating it. You can also put in Vaseline gauze or alcohol-impregnated gauze if it's a bigger size. So a gauze dressing, but instead of putting saline in which dries, you fill it with Aquaphor so that it continues to hydrate the wound. And then you want to protect your skin. You can put Vaseline gauze, Aquaphor, Adaptic, zinc oxide, calmoseptane, almost anything on the skin itself to protect the skin. If it's a dry wound, you can just use Vaseline gauze or Adapt to keep it from drying, and you can basically just put it over the whole thing if it's a shallow wound. And then what do you cover it with? I usually cover with just dry gauze. Paper tape is pretty good tape to use. There's also the cloth tape, the really nice, I can never remember what different brands are called, but there's some nice tapes that don't irritate the skin. I really like things like FlexiNet or stretchy stuff that, or Coban that keeps the dressing on without actually having adhesive. And you can use a polyurethane foam if it's very exudative, because polyurethane foam absorbs and protects, and it's nice for traumatized areas. But if you use just those few products out of the 1,000, I feel I could dress 80% of the wounds I see just using those. I have to admit, I don't know that industry likes me very much because there's all these fancy products out there. I know you've all seen their silver products. I didn't put that in here. If you've got a highly contaminated wound, I think silver is a great drug to put in the wound, but I don't think you should use silver on every wound, because most wounds, if you just get them in the shower, will be perfectly clean and happy. But a small number of products, not that modern, but pretty modern, can help these wounds heal a lot better. And when you change a patient from the wet to damp to one of these dressings, they are grateful as they're walking out of your office because they are experiencing less pain. So think about going to some of the more modern dressings. So I just want to spend a few minutes now talking about these two extra topics. Transcutaneous oximetry. So the transcutaneous oximeter, these are what the boxes look like. It's basically a little Clark electrode that measures oxygen in the skin. It's heated, so it liquefies the stratum corneum so oxygen can diffuse out so you can measure it. It was invented to measure arterial PO2 on the chest, and it works actually pretty well in neonates. It doesn't work for beans in adults because our skin is too variable and too thick. But it works great on the legs for predicting whether you're going to heal. And if you look at normal values, they've all been done at sea level. I'm not entirely clear what a normal value is here, but it seems to be about the same. 50 to 70 is a normal value, and if it's less than 40, trouble's coming. The thigh is normally higher than the calf, which is normal than the foot. And you can put them on about anywhere. Let's talk a little bit about lead placement. You need to be on intact skin. They don't do well on broken skin because you don't get a seal, and you don't want to be measuring environmental oxygen. Your skin can't be too thick because then the oxygen can't get through the skin, and you'll measure a 0. If you measure on the plantar surface of most feet, you'll get a number of 0. It's not because the number is 0 in the foot. It's because the callus is too thick for oxygen to get through. It's got to be pretty normal looking, and you don't want to put it right over a vessel because then you may be measuring vessel PO2. Some people advocate there's only one, everybody should get the same lead placement, and some people say, well, maybe you should match it to the purpose of the study. I would say it depends on the purpose of the study. So if you're looking for where to amputate, then by all means, do a below knee site, an above knee site, a transmetatarsal site. If you're looking at wound healing, put a couple around the wound to see how it's healing. I actually always do both feet, dorsal surface of both feet to see what arterial flow is like, and around the wound and the opposite calf. And if it's vascular assessment, you want to think about what the blood vessels are and where they're going and where you're trying to test them. So if you're looking at capacity to heal, again, you want to do around the wound. I usually do proximal, distal, and lateral. There's a study that shows that lateral is usually the lowest in venous ulcers. In arterial ulcers, it's usually distal. I also do whatever makes sense, because sometimes you can't put it exactly where you want to because you can't find good skin there. So you do it wherever closest you can. And then bilateral dorsal feet, which tells me if this wound is hypoxic, is it a local problem, a regional problem, or global? So if it's bad on both feet, maybe they're just hypoxemic. If it's bad on one foot but not the other, then it's arterial insufficiency. If the feet are both fine but the wound is hypoxic, it's local vasoconstriction or some other process that's going on locally that you can work on. That arterial revascularization is probably not going to help. So we use transcutaneous oximetry widely to tell us how wounds are doing. Do they have arterial disease that needs to be corrected? Do they have local vasoconstriction? What's going on? There are some times when I wait to do the test. If they have a lot of edema, there's no point in doing transcutaneous oximetry because it's going to be low. Once you get rid of the edema, it's worthwhile doing it again to see what it means. Similarly, if there's an acute infection, the white cells are consuming all the oxygen. Not very helpful to get the infection. If they need debridement, again, that can be consuming a lot of the oxygen, so let's clean them up. If they're hypoxemic, then you're going to get a low number. You won't know what it means. However, you can give them nasal cannula oxygen to get their arterial PO2 up to close to normal, and then you can get a reasonable test. And in fact, my standard is if the person's saturation is less than 94% on room air, I give them nasal cannula oxygen to kind of get them a room air value that's somewhere around 94%. And if they're having an MI, not a good time to measure transcutaneous oxygen. That's my quick transcutaneous oximetry. It's very highly valuable. I showed you today at the beginning that it's predictive of whether someone's going to heal. Good to get someone who knows what they're doing to do the measurement. So how do I approach a chronic wound? I start out with the basics. I find about half of my patients, if all I do is tell them to stop using hydrogen peroxide and wear a compression stocking and a good dressing, they heal in a couple weeks and life is good. Then there's the half who don't. So I start with the basics, and I expect them to start making progress, about 15% per week or something. It needs to be getting better. You need to measure it so you know it's getting better. And then if the healing isn't progressing or the wound's getting worse, or if I know the patient's at high risk for failure, I may jump into something more adjunctive right to begin with. There's tons of adjunctive agents. I'm talking about hyperbaric oxygen here today, partly because I know about it, and partly because that's what I was asked to talk about as a thing that people are interested in. So what is hyperbaric oxygen? It's a systemic treatment where the patient is entirely enclosed in a chamber that's pressurized to 2 to 3 atmospheres while breathing 100% oxygen. It's usually at 2 to 2.4 atmospheres for 90 minutes a day for 20 to 60 treatments. And there are monoplace units where the patient is in 100% oxygen, which are in a number of places around the valley, and multiplace chambers, and there's a couple of those in the valley. IMC just opened a new one, which is basically a room that's compressed with air, and then patients wear a hood to get the 100% oxygen. And you can treat critically ill patients. So here's a picture of a multiplace chamber. You can see there's a lot of stuff outside to help you run it. The patients sit inside and wear a hood, fairly comfortable. You can do a lot of things in there. And here's a multiplace chamber. They're nice, they're big, they're plexiglass. Patients are pretty comfortable, they watch TV. And here just evidence that you can do critical care in even a monoplace chamber. They've got all these pass-throughs. We can use a ventilator. We can give all kinds of drips. We can use monitors while they're in the hyperbaric chamber. So why would you use an adjunctive therapy? Again, it can induce healing in a stalled wound. It can prevent impaired healing in patients with obstacles. It's not going to work if you don't do it rationally. So I have a lot of patients come to me and say, you know, I heard about this miracle cure. Now, these are patients who aren't wearing their compression stockings and aren't wearing a dressing and aren't complying with. And I say, well, let's start doing the right thing first, because I can tell you that if I give you the miracle treatment, it's not going to work because there's no miracle treatment for your underlying chronic disease. So hyperbaric oxygen, we're going to use it in the right people for the right reasons. How does it work? One thing it does is it corrects hypoxia because it causes an increased diffusion distance for oxygen. That's actually a minor component of what it does because you're only in the chamber for 90 minutes and the tissue oxygen level goes back down to where it was within an hour of coming out of the chamber. What really is useful about hyperbaric oxygen is tissue hyperoxia. So for that 2-hour period, you get a high level of oxygen. And studies looking at transcutaneous oximetry and diabetic foot ulcers have shown that you have to get the wound oxygen level over 200 to have a good chance of success with the treatment. So if you have a person whose oxygen level only goes to 100, they're unlikely to heal, even though that's higher than a normal wound oxygen level. So it's acting pharmacologically. How does it act pharmacologically? It actually increases appropriate inflammation. It makes your white cells more effective. It gives you more growth factors. It increases gene impression, and it induces vasculogenesis and angiogenesis. You get more blood vessels in hyperbaric oxygen. You actually also get the opposite benefit, which is reducing inappropriate inflammation. It actually prevents leukocyte activation and adhesion so that you don't get it prevents ischemia, reperfusion injury, or at least ameliorates it. And finally, really recent data that are very exciting is when you take a diabetic patient and give them hyperbaric oxygen, you mobilize endothelial stem cell precursors from the bone marrow, and they actually get to the wound and help to improve healing. So does hyperbaric oxygen work? Well, for treatment of diabetic ulcers, I'm just going to give you one study. A group in Italy, they studied 68 diabetic patients who had ischemic diabetic foot ulcers, and they were randomized to get hyperbaric oxygen or standard treatment. And this is one of my favorite studies. It's one of the few studies in ischemic ulcers where there's standardized, appropriate, and reported ulcer management. Mostly, I think they just leave them to dry in air. And they showed a substantial reduction in major amputation, and they also showed that transcutaneous oxygen went up substantially in the hyperbaric oxygen treated group, so you actually have a mechanism for why they had fewer amputations. They had better blood supply. So when should you use hyperbaric oxygen? Wagner grade 3, infected diabetic foot ulcers. Patients who have late effects of radiation, it actually causes revascularization of radiated tissue. Chronic refractory osteomyelitis, it makes your white cells work better. You need to do that in combination with surgery, or you're not, hyperbaric oxygen does not bring dead bone or dead tissue back to life. Progressive necrotizing infections, again, makes the white cells more effective. Compromised flaps or skin grafts, crushed injury, and ischemia reperfusion injury, which I talked about a little before. These are all part of the same problem, which is a lot of inflammation that's causing damage and hypoxia. I just want to show you one of my favorite patients. This woman was, at this time, I think in her 80s. We've been taking care of her for about 15 years. She has diabetes. She has bad osteoarthritis and has had every joint replaced. She has bad venous insufficiency. She's very tall, but she's very active. She swims every day. She's out. So about a week before this picture, she was at the grocery store and ran into the bread cart and basically sliced flaps of both her shins. So she came to see us, and this looks kind of black, like it might necrose any minute, and she's got a drain, and it's been sutured down, and we're worried about it. And she's had a bunch of injuries like this because she's so active, and they usually take us a year or two to heal. We said we had just gotten a hyperbaric chamber in San Francisco, which there's a plethora of them here. There's only one place that has them in San Francisco, and that was only in 2000, so it's a different world there. Here she is a couple of weeks into the hyperbaric oxygen therapy, and you can see she's saved most of the skin, and the flaps are looking good. She continues to do better and better, and here she is almost healed about 4 months later. And here she is. You can't even actually see a scar from it, so she really saved the skin flap. So a couple of years later, she was actually at the gym with a personal trainer on the treadmill, and the thing started going fast, and I don't know why the personal trainer didn't turn it off, but she literally flew off it on her knees and degloved her knees. So we put little skin, basically took her skin and created skin flaps on her knees, put her in the chamber, and here she is a week later, and it's healed up. So this is an example of a nice place to use hyperbaric oxygen to deal with a compromised skin flap, which isn't created by a surgeon, it's created by a patient. So in summary, there's nothing that replaces good wound care. You want to address the basics in all patients. They need good perfusion. Supplemental oxygen is great if they're well perfused. Nutrition, moist wound care, debridement, cleansing, and protection. And you can use adjuncts to create a healing environment in patients who have an impaired healing capacity, but they won't heal with those adjuncts unless you do the basic stuff right. So I think we have a couple minutes. I'd be happy to answer questions. I was going to show a few pictures of wounds. I'll whip through my pictures of wounds. This is a skin tear. Don't cut off the skin. Clean it up, tape it down, put a dressing on it, leave it alone for a week, and it'll reepithelialize and stay there. It's a venous ulcer. That's also a venous ulcer, highly inflammatory. These aren't ulcers, but you can see this person has venous insufficiency. They've got the hemosiderin staining of their legs. That's Charcot foot. You can see why they get ulcers. There's a standard plantar foot ulcer, and they're caused by pressure, and you have to offload them. Here's something that looks like callus. The reason you want to debride off callus is because oftentimes there's an ulcer underneath it you'd really like to treat. And here's evidence that when you've got a diabetic, it looks like just a little hole, but it turns out the whole foot's involved, and they need to be aggressively debrided and get rid of the dead tissue, and this guy would probably benefit from hyperbaric oxygen. This is a guy with arterial disease and pressure ulcers of the heel, and we know pretty well he's going to end up with amputations. Best to avoid these by floating the heels in those post-op patients. Here we have embolic events. Those things are going to fall off. But you want to keep an eye on the rest of it, and keeping it warm, potentially hyperbaric oxygen, can save the at-risk. Here's pressure ulcer, and you can see it's highly inflammatory and has a lot of stuff on it. It needs to be debrided and cleaned up, and you need to get the pressure off. Another pressure ulcer with all that slough. Another pressure ulcer that goes very deep and may look pretty clean on the surface, but may be in deep trouble down low. And I'd be happy to answer any questions if anybody has them. So calcium-alginate can be left on for up to a week. I usually, if they're able to do their own dressing changes, try and have them change it every day or two so they can get in the shower and then put it back on. It depends a lot on the patient and the wound, and you kind of got to figure out what's the right thing for the wound. But the calcium-alginate can stay on for up to a week. We'll go there and then there. And honey is actually a known good wound dressing. I don't like it very much because it's a sticky good wound dressing. There's a special kind of New Zealand honey that's supposed to be the best, but honey, actually, you can keep honey forever. It does not get infected, so it's a very good antibacterial, and it does help healing. I just would like someone to come up with a honey that doesn't get sticky all over your house. Yes?
So where do you get good compression stocking? It seems like it's hard to get patients to find stocking, especially a lot of these patients that come in and the venous insufficiency have to deflect. Even after we compress them down with base bandages, it's hard to get the right size stocking for the right place.
So I like to send those patients to lymphedema clinics, and there's a couple in the valley here because they do a great job of measuring them, because the key thing for stockings is to get them measured correctly. And I have to say, I haven't been here long enough to feel really comfortable where the really good places are that do good measurements. But there's a lymphedema clinic at IMC, and I know there's a couple others, and they are great. And they're also great at kind of getting the edema out so that they can get them skinny and get them compressed right.
Then what about uni boots versus just using ace wrap? A lot of those people who are bigger, so they'll
Right.
wound over the
So Una boots or the 3M two-layer wraps or all those Pro 4s, whatever, they all work about the same. I like something that they're encased and they can't get at. I use an ace wrap in a compliant patient who can do it every day to kind of get going, but then I will move on often to either the two-layer wrap or a stocking pretty quickly. No, the Una boots and those can go for a week. The ace wraps, I usually have them rewrap every day. Is there any questions over on that side I don't want to ignore? Isn't that normal? Yeah, and actually I'm now the vice president of the Wound Healing Society, the first anesthesiologist to do that. But there's a lot of anesthesiologists in hyperbaric medicine. I got there because I started in surgery and did a research fellowship in the wound healing lab and stayed there. And I justify myself now because surgical site infection prevention is really highly in the hands of anesthesiologists. So if we keep patients warm, give them the right amount of fluid, give good pain care control, and give them antibiotics at the right time, we actually can prevent infection. Well, you cannot smoke in the chamber. A lot of people, so smokers in the studies have horrible outcomes, and if they get hyperbaric oxygen, they still have horrible outcomes. Some people will treat them if it's a limb-threatening problem, but they usually get them to sign a contract saying, I won't smoke for 2 hours before my treatment. If you can get people to quit smoking, it makes a huge difference. I think if we warmed their leg in the chamber or before they got in the chamber, that might make a difference. That's one of my little things I'd like to test at some point, but I haven't gotten around to it yet. So it's a big problem, and I find it interesting that if you have a limb-threatening problem, you can't quit smoking or do whatever it is I ask you to do, but I think oftentimes it's just futile. So I didn't say that. Antiseptics helps are bad because they're anything antibacterial. It's that cytotoxic agent thing, and it just tends to make your wound not heal well. So I just want something that's a detergent effect that cleans things off the wound, but I don't really want to have a lot of antibacterial stuff on the wound. If I need something antibacterial, I'll probably use a silver impregnated dressing, and that works really well, but just Dove, nice gentle soap and water is the best thing. So pain can really inhibit debridement, and So I think if you can get the pain controlled over the course of the week, it's usually easier for the debridement. I am in a good position. I can do ankle blocks and things to help myself with that. It's one of the biggest problems for debridement, and I think taking advantage of the operating room and giving anesthesia for debridement is a really good idea, especially like at the beginning, just get everything cleaned up. It's hard to get that done, but it's a good idea, and particularly with those diabetic, hideous feet, just take them to the OR, numb them up somehow. I mean, spinal, general, I don't care, and that works well. For MRSA, I'm not quite sure what the MRSA question is. MRSA is not a particularly much worse bug than MSSA. It's just, it tends to not be treated by the first antibiotic you use, and then you have this problem of spreading it to other patients. I treat everybody as though they have MRSA. So, washing my hands a lot, changing my, I do hand hygiene about every minute. So I think just standard precautions are what you need to do. I don't think you need to raise some alarm, and I just assume everybody's got it. I culture almost no one. I only culture people if I'm going to treat them with antibiotics to find out what the bug is. Because all wounds grow bacteria, yes. It's an interesting idea. There's, I don't know that there's outcome studies for it. I will say Trental, pentaxiphyline, works for venous insufficiency ulcers, which is interesting. One more in the back, and I think we have to. When do I treat with antibiotics? So all wounds are contaminated. If there's a lot of contamination in the slough, I'll use topical antimicrobials, usually silver. If there's invasive tissue, red tissue pus, then I'll give antibiotics, and then I'll culture and use antibiotics. But by and large, unless there's invasive tissue infection, there's no role for antibiotics in wound care. Okay, thank you very much.